Hi, I'm Dr. Ben Creelan from Moffitt Cancer Center. I'm here at SITC 2024, and I'm grateful to present on behalf of our investigators, patients, and translational scientists updated results of lifileucel plus pembrolizumab in metastatic lung cancer. We know that frontline therapy with immune checkpoint inhibitors plus chemotherapy, our gold standard, has poor outcomes for most patients, with a median PFS of maybe 6-7 months. And we also know that cell therapy using tumor-infiltrating lymphocytes, TIL, can induce responses in a select subset of these patients with 2, 3, 4 prior lines of therapy. Especially the tumors that have absent PD-L1 expression that traditionally just don't respond to pembrolizumab monotherapy was the patient subgroup that were especially interested in combining immunotherapies of other types for. So in this phase 2 trial, COM202-3A, we enrolled patients with immune checkpoint naive advanced non-small cell lung cancer that were required to have at least one prior tumor resectable for TIL and at least one additional tumor with measurable disease. These patients were allowed to have had prior platinum-based chemotherapy, but they were not allowed to have prior immune checkpoint inhibitors. And so patients had a resection using the standard lifileucel 22-day manufacturing process of tumor-infiltrating lymphocytes, followed by one dose of pembrolizumab, and then they commenced to receive the lymphodepletion chemotherapy, interleukin-2 using the conventional dosing of up to 6 doses of IL-2, followed by pembrolizumab, immune checkpoint inhibitor, every 3 weeks or 6 weeks for up to 2 years. Now, when we look specifically at the EGFR wild-type subgroup here, we have an overall response rate of 64% of patients. Almost all these patients were PD-L1 negative tumors, which is a population historically that's had little responses, few responses to pembrolizumab as a single agent. So we're really provoking the idea here that the TIL is synergistic with the pembrolizumab in this setting and working in a completely different way by providing live T cells that migrate back into the tumors. And if we zoom in further, we see that the disease control rate overall was 78%, with a median duration of response that was not reached despite achieving a really long duration of follow-up in this trial. And another thing was that in EGFR mutant patient, we see a complete response, which would be completely unheralded expectation for pembrolizumab alone in this EGFR mutant population. So this is a waterfall plot showing the max decrease of tumors from the baseline CT scan, which shows the majority of patients obviously have decrease in their tumor size, regardless of the tumor immune infiltrate as defined by the PD-L1 tumor proportion score. And this is a spider plot which just speaks to the sustained durability of the radiographic responses of these patients going out past 2 years. And indeed, several of these patients, again, still going out past 2 years, have had durable responses, well past the cessation of their pembrolizumab immune checkpoint inhibitor, as shown by this swimmer's plot, which shows all the patient details. And these are the patients that have had responder, that have responded to the therapy. Now, treatment adverse events, we didn't see any new safety signals emerging with the addition of pembrolizumab to the lifileucel cell therapy, with a proportion of patients experiencing some decreased oxygen saturation, requiring supplemental oxygen during the lymphodepletion, the cell infusion, the IL-2, which, it's part due to their underlying cancer, the capillary leak from the IL-2, and the fluid shifts that we see during chemotherapy. And indeed, along with that, we really don't see that these adverse events occur much after the first 14 days after cell therapy. As you can see in this graph, almost all the adverse events occur in the first couple weeks of the infusion. And remember, these are adverse events of any cause throughout the course of the study. So in summary, we see these deep and clinically meaningful responses by adding lifileucel cell therapy to pembrolizumab for these immune checkpoint naive stage 4 non-small cell patients, which is a higher proportion than you'd expect with pembrolizumab alone. which really supports the idea of further trials in the front line in combination for patients with metastatic EGFR negative lung cancer using lifileucel. And these are the conflicts of interest reported for our investigators that conducted the clinical trial. Thank you.